Bismillahirrahmanirrahim. Hi everyone. This is the first video about abdominal pain, and we are still under the category of pathologies that might not be revealed in imaging, abdominal imaging, including CT scan. So in this video, I'm going to talk about the third category of pathologies that might cause abdominal pain without obvious findings in the CT scan, and that include the nerves inside and outside. So there's some diseases that associated with damages to central peripheral nervous system that can cause abdominal pain, and these include diseases of the spinal nerves or the spinal roots, or diseases of the autonomic nervous system, or what they call dysautonomia. So basically, an example of disease of the spinal nerves or roots, an infectious cause here that you are familiar with, is herpes zoster. So herpes zoster, sometimes the prodrome of herpes zoster infection or shingles can present with pain in the dermatomal distribution without the rash, before the rash. In fact, the patient might have the pain 1 to 5 days before the rash, which can be challenging sometimes. Sometimes can be even longer than 5 days. So the clue here is that the pain is usually continuous or intermittent, and it's described as burning pain or tingling sensation. That could be a really useful clue when the patient is describing the pain to you, and that's why it's important to ask about the character. Hyperesthesia also is relatively common and is also a very useful clue. A lot of times, if the patient is covered by sheets, and when you try to remove the sheets to examine the patient, that if the sheet touches the skin, that might cause some discomfort and pain to the patient, and might elicit the pain, and that could be a useful clue. Some patients might have some mild constitutional symptoms, maybe some mild fevers. Another useful lab is to do the inflammatory markers. Some patients might have high CRP, C-reactive protein. ESR tend to be normal or a little bit high, but CRP might be more sensitive in these situations. And again, remember, the patient might have the pain 1 to 5 days before the rash, or even longer. Nerve impingement, also relatively common. Usually not classical with acute abdominal pain, but they still might present with abdominal discomfort. For example, pathologies from disc herniation or degenerative spinal disease or tumors or abscesses or hematoma. Different pathologies can cause nerve impingement. And the pain is usually lancinating or described as piercing or stabbing. Pain is made worse by movement of the spine or by coughing or sneezing. Any cause of increased intra-abdominal pressure might elicit the pain. That could be a useful clue. There might be some muscle spasms, and you might actually observe that during the exam as well. Maybe the pain might be relieved by abdominal palpation compared to intra-abdominal pathologies, when palpation actually make the pain worse. Hyperesthesia, again, is a very useful clue. So maybe when you start examining the patient, start with superficial palpation. If you observe that the patient is having a lot of pain out of proportional to the degree of palpation, that might be a useful clue. Dysautonomia, common causes include diabetes, of course, uremia, Parkinson's disease. These are commonly affect the peripheral nervous system, but not always the autonomic nervous system, but they might. So keep those in mind. They might present with very non-specific GI symptoms, but the clue for those is associated symptoms with other manifestations. For example, changes in heart rate. They might be tachycardic at times without an obvious cause, or bradycardic, especially at night. Blood pressure as well, labile blood pressure, sometimes high, sometimes low. Patient might have temperature dysregulation. Temperature might go up or down. Patient might feel cold or warm. Sphincter disturbances may have urinary retention or incontinence, constipation. Sexual dysfunction also might be a presenting symptom. So these are the clues to consider causes of dysautonomia. These pathologies, they have a specific test or diagnostic test to do to make the diagnosis, but It's really mostly based on clinical ground. Now, mesial temporal lobe epilepsy. This is really a little bit less common cause of abdominal pain. Usually, there's other manifestation that can give you a clue, but it's worth mentioning here. It's kind of an interesting entity. Actually, a relatively common cause of focal seizures with impairment of consciousness. This usually happens in young adult or adolescents. Abdominal aura is also kind of characteristic, often described as a rising epigastric sensation, but also patient might have some ictal vomiting or hypersalivation as part of the GI manifestations. And of course, the diagnosis is made by clinical manifestations, EEG changes, and MRI or brain imaging changes. For the clinical changes, they may have automatism. That could be a useful clue. So just repetitive movement like lip smacking, chewing, or hand movement. Stirring sometimes, just emotional disturbances, could be emotional labile. Hallucinations also. And then EEG might show some temporal slowing, some temporal spikes. That could be a clue, but imaging is very important. So MRI of the brain might show some hippocampal sclerosis. So the clinical, again, is made by combination of all these. And it usually responds to surgery more than anti-seizure medications. And that's why it's really important to recognize because the treatment is a little bit different, and patient might presenting with really difficult to titrate anti-seizure medications despite being compliant. So these are just some of the pathologies in the central and peripheral nervous system that can be associated with some abdominal discomfort and abdominal pain. And we'll see you in the next video. Thank you.